Dr. Susana Salazar, and I want to thank you for joining us in this symposium. For us, from the INSA group, it's very important to share these academic spaces with you. Today, I'm going to talk about management of the uterine niche in the infertile patient. About C-section, the World Health Organization recommends as ideal C-section rate of 10 to 15% of all births. However, in the percentage of C-section delivery in South America is 42.9%. In Latin America is 40.5%, North America is 32.3%, and Europe 25%. This has led to a worldwide discussion about the complications and consequences of the procedure, which are also an increasing number. Clinical guidelines aim at reducing non-medically indicated C-section delivery and induction of labor under 39 completed weeks have been released by the American College of Obstetricians and Gynecologists in an effort to reduce such births. There has been an increasing awareness of long-term gynecological problems after cesarean, like chronic pelvic pain, dyspareunia, dysmenorrhea, postmenstrual spotting, and even infertility. But why secondary infertility? Because the persistence of blood resulting in chronic inflammation may possibly lead to alter cervical mucus, sperm transport, and interfere with embryo implantation. Accumulation of fluid in the endometrial cavity that produces a hostile environment for the embryo, increasing the risk of implantation failure or recurrent pregnancy loss. The hypotheses are, first, detrimental environment for sperm penetration and implantation. Niche-related accumulation of intrauterine fluid impairing implantation, altered immunobiology and/or increased inflammation when an niche is present. Distorted contractility of the uterus caused by fibrosis or interruption of the myometrial layer in the side of the niche, and accumulation of mucus and old blood in the niche, which may impair sperm penetration. Some studies report less fertility rates after C-section compared with patients of natural delivery. Pregnancy rates are 10% less in patients with C-section compared with women with vaginal birth. Also, long-term obstetric sequelae seem to be on the rise in the form of spectrum of disorders starting with CS, scarred ectopic pregnancy, increased incidence of placenta previa, varying degrees of adherent anterior placenta previa, including placenta accreta, associated with major maternal morbidity and even mortality. C-section scar defect, also called niche or diverticulum or ismocele, that is becoming more prevalent in gynecological and obstetric practice. Ismocele is a pouch-like defect in the anterior wall of the uterine isthmus. Occurs as a complication of a previous C-section. It describes the presence of a hypoechoic area with the myometrium in the isthmus with discontinuation of the myometrium at the site of previous C-section. Large niches are uncommon, with reported varying incidence of 11 to 45% depending on the definition used. How is the classification of the ismocele? First, large defects. When myometrial reduction of 50% of the wall thickness or even 80% by some authors, it may also be classified as a residual myometrium less than 2.2 millimeters by transvaginal ultrasound and less than 2.5 by HCG. They can also be classified as asymptomatic or symptomatic. For management purposes, Morota et al. Adopted the cutoff residual myometrium less than 3 millimeters as a large defect and a residual myometrium more than 3 millimeters as a small defect. Incidental finding on C-scar defect on hysterosalpingogram and pelvic sonogram has been noted for many years before the first link to postmenstrual bleeding was made about 2 decades ago. C-section scar defects have also been linked to pain and infertility. It may be asymptomatic or present with abnormal bleeding due to accumulation of blood in the reservoir-like niche and impaired contractility of muscle fibers surrounding the defect. Other common symptoms are chronic pelvic pain, including dysmenorrhea, dyspareunia, vaginal discharge, and secondary infertility. The exact prevalence of isthmocele is unknown and is related to the method used by access the defect. In a recent symptomatic review, Tulandi and Cohen have found that the prevalence of isthmocele ranges from 24 to 70 in the transvaginal ultrasound examination and from 56 to 85 in the SHG. The prevalence is higher in those with symptoms, ranging according to the literature from 89.2 to 84%, with postmenstrual spotting as the main symptom. Which are the predisposing factors for CS scar defect? Concerning the etiology, 4 hypotheses have been postulated by Verburg et al. On cases of isthmocele. The first hypothesis concerns the location of the hysterotomy, proposing that a low incision in the cervical part of the uterus is made through cervical tissue, which contains mucous glands, and the mucus produced during the healing could dilate the suture rims in the myometrium. This theory is corroborated by several studies that have associated a higher prevalence of isthmocele in patients with cervical dilation more than 5 centimeters long, longer duration of labor more than 5 hours, or lower station. The second hypothesis is related to surgical technique. In a complete closure of the uterine wall, the improper closure or even no closure on the deeper muscular layer, usually unintentional or related to non-perpendicular sutures and endometrial saving techniques, may lead to an irregular myometric closure, thus causing the development of isthmocele. The third hypothesis relates to early adhesion development in the hysterotomy scar and the anterior abdominal wall, peeling the edge of a wound and impairing the healing due to those contracting forces on the uterine scar. This mechanism is even more exuberant in a retroflexed uterus, in which those contracting forces are increased, potentially decreasing blood flow to the healing tissues. And fourth, patient factors, suggesting the presence of an individual genetic predisposition contributing to an impaired wound healing. These are other predisposing factors for CS scar defect. Several risk factors have been related to the development of the isthmocele. However, there are few associations proven to date. Ofili Givovi et al. First present an association between isthmocele and multiple previous C-sections, retroflexed uterus, and failure to identify the C-section scar during repeat C-sections, later corroborated by several authors. The results were, first, cervical dilation, more than 5 centimeters, and station of the presenting part as C-section streak increased the risk. Retroflexed uterus and duration of active labor more than 5 hours associated with a large niche. Scar defects in 61, 81, and 100% after 1, 2, and 3 C-sections. Full thickness suturing, including the endometrium, reduces the rates of uterine niche. Less cervical dilation was associated with niche formation. Double layer closure decreases the risk. Other factors include increased gestational age at delivery, twin pregnancies, premature rupture of membranes, and preeclampsia. Looking of the first layer in single or double layer closure was associated with lower myometrial thickness compared with non-locked double layer closure. Diagnosis. There are no definitive criteria for the diagnosis of isthmocele. Various imaging methods include ultrasonography, sonohysterography, hysteroscopy, and magnetic resonance imaging can be used to access the anterior uterine wall. Transvaginal ultrasound. That's initial and most usual approach. The early proliferative phase best shows the deposit of blood within the isthmocele, allowing its identification even without the necessity of saline infusion. The defects have been described on the transvaginal ultrasound as an anechoic triangle defect in the myometrium with the base of communicating to the uterine cavity, or a deformity on the anterior isthmus. According to all experts, there should be two different measurements performed in the length and the width of the main niche, is wider higher up the niche base. Both measurements are at the base of the niche, as well as the largest distance should be reported. If visible, branches should be measured and reported. In that situation, the depth of the niche and the residual myometrium of the main niche, and including a branch, should be measured separately. Length is measured in the sagittal plane. Length should be measured at its biggest. Both the longest length and the length at the niche base should be measured. About the depth should be measured at its biggest. Both depth of the main niche as well as the depth of the branch should be measured and registered. The residual myometrium of the remaining niche should be measured in the sagittal plane, where the main niche has the smallest residual myometrium. The residual myometrial thickness should be measured at its thinnest, no matter what direction, perpendicular to the serosa but not necessarily perpendicular to the uterine cavity. Both the thinnest residual myometrium of the main niche as well as the thinnest residual myometrium, including the branch, should be measured and registered. Fibrosis is not included in the residual myometrium measurement. Second, the sonohysterography. It is more sensitive and specific for the identification by feeling the defect and providing contrast. Third, an hysterography, HSG. It can access the isthmocele but cannot measure the myometrial thickness, which is a limitation of this method. Hysteroscopy enables the direct visualization and confirmation on the isthmocele, usually described as a pouch or a discontinuity of the anterior uterine wall. It allows visualization and potential treatment. However, it may not access the residual myometrium thickness. Transvaginal ultrasound and SHG can both be performed in the office, are more affordable than MRI, and less invasive than hysteroscopy, and procedure reliable measurements. If an isthmocele is suspected, several authors recommend SIS as a diagnostic study based on its greater sensitivity and specificity for planning surgery and research purposes. The treatment of isthmocele ranges from clinical management with expectant or pharmacological treatment, surgical treatment, and hysterectomy to sparing techniques, including hysteroscopy, laparoscopy, laparotomic, or transvaginal procedures limits to the defect of the site. The decision to treat takes into consideration the size, the defect, symptoms, secondary infertility, and plans of pregnancy. In case of incidental diagnosis of asymptomatic smooth and no plans of future childbearing, clinical observation and no surgical intervention are usually recommended. Medical treatment. Hormonal therapy symptomatically relieves AUB. Oral contraceptive pills are suitable if pregnancy is not desired. IUD was not found to decrease menstrual length. Uterine-sparing surgical treatment. Conservative surgical interventions should be considered after eliminating other causes of presenting symptoms. Surgical management. Reports of resolution of symptoms with surgical management of the defect began appearing in the early 2000s. 3 different surgical approaches to management these defects have been described. Hysteroscopy, when the residual myometrium is more than 3 millimeters. Laparoscopic and vaginal. Hysteroscopy nature section or ismoplasty. Hysteroscopy has the advantage of being the least invasive surgical approach. It can be used for diagnosis as well as a treatment and can be performed even in the office if the ismocele is very small. One option is to coagulate the vessels with the ball electrode as we see in this video. Fulgurating the base prevents in situ fluid blood collection. At the end of the procedure, flow and pressure of the descending medium can be reduced to ensure adequate homeostasis. Hysteroscopic nature section or ismoplasty. Hysteroscopy had the advantage of being the least invasive surgical approach. It can be used for diagnosis as well as treatment and can be performed even in the office. If the ismocele is very small, one option is to coagulate the vessels with the ball electrode as we see in this video. Fulgurating the base prevents in situ fluid blood collection. At the end of the procedure, flow and pressure for the descending medium can be reduced to ensure adequate hemostasis. The surgical technique involves the resection of the fibrotic tissue of the lower margin and then the upper margin of the pouch using a cutting loop until the underlying muscular tissue is reached, followed by resection of the inflamed and necrotic tissue of the base of the pouch. The resection of the niche edges setting the wall in continuity to the cervical canal improves the flow drainage and prevents the retention of menstrual blood. Fulguration of the base of the pouch, either globally for targeting visible vessels, enables the removal of the inflamed and congested tissue, preventing the in situ production of fluid and blood. In a systematic review, Abaseviu et al. Present favorable outcomes rates of hysteroscopic resection of 85%, ranging from 59 to 100%, completely solving AUB symptoms in 72% of the cases. Hysteroscopy repair of a C-section scar defect or ismoplasty is associated with an improvement in uterine bleeding in 59 to 100% of the cases and pregnancy rates of 77 to 100%. The procedure is associated with a risk of uterine perforation and bladder injury. In order to avoid these complications, a cutoff of more than 3 millimeters of overlying myometrium has been suggested. Laparoscopy. Before repair can begin, the defect must be identified, and this may be challenging, mainly due to bladder adhesions. For this reason, we recommend a combined laparoscopy and hysteroscopy. The defect is visualized with the hysteroscope, and then by transillumination, the defect can be identified from the abdominal cavity. Using CO2, the scar should be opened from one edge to other. Fibrotic tissue was then excised from the edge of the defect of to access a healthy myometrium, and then facilitate further healing. Before closing the defect, a Higar probe was inserted into the cervix to preserve the continuity of the cervical canal with an uterine cavity. For the first layer, 3 separate sutures were placed to close the scar, with 2 0-becquerel SH. A second layer of separate stitches was applied to achieve a double-layer closure. Peritoneum was then closed using monoclinic running suture. A laparoscopic approach has been advocated for large defect less than 3 millimeters. In the presence of symptoms, the desire to maintain fertility. Laparoscopic isthmocellular repair consists in the resection of the isthmocellular edge in order to excise the scar tissue, closing the defect in 2-layer sutures. And what about the reproductive outcomes? This is a systematic review published in 2014. 7 studies reported on fertility and pregnancy outcomes. A total of 78 women were reported to have fertility problems, of whom 72 later conceived, 92%, 67 after hysteroscopic resection, 4 after laparoscopic repair, and 1 after vaginal repair. And this is a retrospective observational study, includes 61 patients with recurrent implant failure and isthmocellae who presented to IVF. It demonstrated that hysteroscopic hysteroscoplastic improved the pregnancy and live birth rates for women with a history of recurrent implantation failure and isthmocellae. In our center, we have also seen an improvement in the rate of spontaneous pregnancy or by assisted reproductive therapies after isthmoplasty. My conclusions on isthmocellae in infertility are: isthmocellae is becoming more frequent and often occurs as the only cause of secondary infertility. Isthmoplasty has been shown to restore spontaneous fertility in addition to showing very good results in patients who go to ART. It is convenient to define the presence or not of the isthmocellae in all patients with previous C-section and secondary infertility, and corrected before submitting them to assisted reproductive therapy. Once again, thank you very much for joining us in the second virtual symposium on practical concepts on management of reproductive treatments. We hope that you have enjoyed the presentations and that they will obviously be great use to you in your clinical practice. Thank you very much.